do a 1-2 punch here on CNS infection and white matter disease. So for infection, we're going to handle the big players that you guys know about, of course, but maybe we'll talk about some features that may not be completely obvious, maybe more newer on the horizon, and we'll get into that a little bit. So we'll start with, of course, our classic sort of case, which is a 60-year-old female with metastatic ovarian cancer, presents with absent seizures. And you can see this ring enhancing, pretty rounded, with pretty smooth, symmetric, thickened peripheral enhancement, quite a bit of edema surrounding it on T2 and flare. Already, of course, this is an infectious lecture, you know where your mind is going. And then as we know from sort of first year radiology, what do we look for? That intensely diffusion restricting center, which is indicative of this purulent viscous material. Very dark on ADC. And of course, our primary thought here in this infection lecture is going to be cerebral abscess. A couple of things about cerebral abscess though. If you don't know, if you're not expecting it, you can also have several differential diagnoses, like neoplasm being an important one. Now this is a pretty classic case, but what if the rim isn't as smooth? What if it's a little irregular? What if you're a little equivocal on whether a neoplasm or actual abscess? And sometimes symptoms don't help, right? 30 to 50%, you're not gonna have that classic fever. So you might not even have too many symptoms beyond the mass effect from the edema, which can cause seizures, et cetera. And what we have here is a sign that I like to use, and actually ends up being kind of useful every once in a while, which is the dual rim sign. It's been around for about 10 years now, but it really, if you can look at your T2 or SWI, what you do is you look for the T2 hypointense periphery, which corresponds to that rim of enhancement. You can see this T2 hyperintense internal rim and this T2 hypointense external rim, which of course corresponds to that peripheral enhancement. And this is actually quite a sensitive sign for cerebral abscess. And in this case, it was a pyogenic abscess with nocardia. And it's highly specific. It's not, you don't always get it, but it can be very helpful for distinguishing neoplasm from abscess. You can do it, as I mentioned, on T2 and SWI. And the idea is that this T2 hypointense portion that corresponds to the enhancement reflects this fibrocollagenous capsule that our brain is forming to sort of protect the brain. And then the inner hyperintense rim reflective of granulation tissue. So here's another case, 61-year-old female, possible stroke 3 weeks prior, mass on CT, and outside hospital. So we don't know much. We can see these diffusion hits.
So we're going to finish up today with head and neck infections. And I don't know if it's good news or bad news for you, but I don't have any gross pictures in this talk. Okay, so we're going to first talk about head and neck, meaning face and neck infections, and then we're going to end up talking a little bit about a few brain infections. We're going to focus on complications today. So this is a person who came in presenting with facial swelling and pain. And we noticed that over the left mandibular body, there is focal soft tissue thickening. We don't see any rim enhancing collection. And we look at these coronal reformats now to give us more of an idea of what is involved. So we can see that there's definitely some soft tissue thickening in the subcutaneous fat in the skin. And then we want to look at the deeper spaces of the neck. So the first space we're going to look at is the submandibular space. This is deep to the platysma muscle, but superficial to the mylohyoid muscle. And we can see that there's just a little bit of fat stranding in that space. So we suspect that space is involved with the cellulitis, but there's no frank abscess there. And then we're also going to look at the sublingual space that's deep to the mylohyoid muscle, but lateral to the intrinsic tongue muscles. And maybe there's also a little bit of fat stranding there, but there's no rim enhancing collection. So this, we also notice that the mylohyoid muscle is thickened, the platysma muscle is thickened. So this looks like a cellulitis, and this was treated with antibiotics. Unfortunately, this person came back 1 week later, his symptoms were worsened. And if we look now, we start to see that the soft tissue thickening is deep to the mandibular body, as well as superficial. And we start to see a rim-enhancing collection develop. So at this point, we need to determine whether we think this is abscess or not, differentiating abscess being a ring-enhancing pus collection from just an inflammatory mass that precedes that necrotic central core formation. And in this case, we were able to aspirate 10 ml of pus. So we're feeling pretty good. We've got rim enhancement, we've got pus, this is an abscess. So now we look at this companion case. And this companion case similarly has an area of soft tissue thickening deep to the mandibular body. And there does appear to be rim enhancement. So we think, gosh, this must be an abscess. But in this case, they tried to aspirate and they got no pus. So although it's an important distinction between abscess and phlegmon, because abscess is going to require surgical drainage, whereas cellulitis and phlegmon can be treated with antibiotics, CT has limitations because the imaging findings overlap. If you see a complete rim of enhancement.
Okay, so yes, this talk is on dementia imaging. And we will look at the causes of dementia, imaging of dementia, potential emerging treatments, and ARIA, which stands for amyloid-related imaging abnormalities. So there's a lot of different kinds of dementia or causes for dementia, but some of the big ones would be Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, logopenic progressive aphasia, traumatic brain injury, cerebral amyloid angiopathy, CAA-related inflammation, and normal pressure hydrocephalus. So when a patient presents with memory loss, usually cognitive testing is done, and the referrer will often order an MRI, in part to really exclude some other structural cause for the memory loss. At this point, we encourage quantitative volumetric imaging, and then if there remains clinical ambiguity, sometimes a PET is done, typically FDG because that's reimbursable, but sometimes also amyloid and tau. This is a positive FDG where we see cortical hypometabolism in the temporal lobes here. This is the PET-MR fusion, PET-CT fusion, and another PET-CT fusion image. Just for reference, this is what a negative amyloid PET looks like, as sort of a tree and branch pattern where the cortex is light but the white matter is dark. And this is a positive amyloid PET, diffuse binding of the tracer throughout the cortex. Now, quantitative volumetric imaging will identify and label anatomic structures and then quantify the volumes of those structures. So this AI tool is very good for assessing atrophy in patients with dementia and the patterns of atrophy. It then compares that to a large age and gender matched normative database and provides volumetric tracking over time. Now, there are a lot of different quant companies on the market space. This is what the segmentation looks like with NeuroQuant. This is IcoBrain, Quantib, and Combinostics. This is Darmian, a product in development here. And they all have different reports. This happens to be NeuroQuant, and you see here pertinent structures that might be related to dementia. The quant can be used in multiple other things as well, which we'll talk about in a different lecture. But the hippocampus, the entorhinal cortex, and the lobar cortices. Anything in the pink here is more than 2 standard deviations outside of the mean. And this is the triage brain atrophy report. Again, more structures listed here, and the red boxes are statistically significant 2 standard deviations outside of the mean. This is IcoBrain's report. It's slightly different company, but again, the pertinent structures, anything in the blue is at the 1 percentile, and this is sort of a spider graph that points to different lobes in the brain. This is a Combinostics report. It actually predicts what kind of dementia pattern you might have. Here it's predicting off of the MRI that this patient might have Alzheimer's. Now here's a look at some different PETs, amyloid PET, tau PET, and FDG. Normal on the top here. So with amyloid PET, we get that diffuse pattern of binding throughout the cortex. Tau would be, for example, like an Alzheimer's patient, would be temporal lobes, parietal lobes, posterior cingulate gyrus. And FDG PET would have a similar sort of pattern as the tau, again, for example, for Alzheimer's, parietal, temporal, and posterior cingulate gyri. Here's some FDD PETs and different patterns in different diseases. Here's Alzheimer's, which we just talked about. FTD would be really more frontal lobes, temporal lobes, anterior cingulate gyri. And dementia with Lewy bodies will often look like an Alzheimer's pattern, but also involve the occipital lobe.